Thank you so much, Akshay. Thank you for inviting me for this instruction course. I've just simplified the title to neurological aspects of ptosis, and a part of it has been covered beautifully well by Savri and Akshay. So, why it is important to look at a neurological aspect of ptosis? As was mentioned, most of these conditions which can come to you with ptosis, and ptosis as the only sign, are progressive. And if you miss any of those conditions and if you go ahead and operate, you may end up in a problem. As you see in this young man who presented with ptosis, he was found to have a probable progressive muscle problem. We were not very sure of the diagnosis. Went somewhere else, got operated, and this is a post-operative picture. Down below, you find that ptosis, in fact, has increased a little bit, and now he has a little lag in the downward position because of the surgery. So it's very important that we make sure that any progressive condition, most of it in neurological region, they are ruled out before we embark on surgery. And what are we really looking at? We are looking at nerve problems. It can be a third nerve which supplies the LPS muscle and can come to us with ptosis. In third nerve, because of the fellow travelers, we are not really worried about diagnostic dilemmas, but we are then worried about how do we progress further. Uh, the other nerve issues which can present to us with ptosis would be Horner syndrome, and I'll be covering both by an example of a case. Myopathies and myasthenia, as was covered beautifully by Akshay. So let's look at this patient. This is a 65-year-old gentleman who comes to you with complete ptosis. He has a vasculopathic risk factors, and as you see, there is a complete ptosis. The eye is exotropic, and when the patient looks to his left, there is limitation of adduction. The abduction is normal. When the patient looks up, there is limitation of elevation, and he looks down, there is limitation of depression. And as you can probably see, the fourth nerve is functioning. There is a torsion of the eye when the patient looks from up to down. And it's not very clear here, but the pupil was of normal size. So here is a 65-year-old gentleman with a complete ptosis, no other cranial nerves involved, and the pupil is normal. What should we do next? Well, by the textbook thinking, we'll say that this is a classical case of third nerve palsy because of ischemia or ischemic third nerve palsy. And we can observe the patient, and these are likely to improve. 90 to 92% of these patients where third nerve palsy is because of ischemia would improve between 3 to 4 months' time. Let's look at a few examples before we come back to this thought process. Now, this is a lady who was told that she has RAPD and that she has a ptosis. You can see that there is a ptosis of the right eye, and I will be checking optometrically using the torch just to highlight one of the important signs that one should look at when you are examining a patient with a third nerve palsy. The patient looks to the left. The adduction seems to be fine. The abduction of the right eye is fine. But as you notice here, the right pupil is larger than the left pupil. So there is a ptosis with anisocoria. And you'll find here that elevation is depressed, and there was a mild limitation of depression as well. So here now we are dealing with a partial third nerve palsy with involvement of people. Obviously, the management is going to be different. These are the patients who require an urgent neuroimaging. And we'll see one more example before we discuss as to what kind of neuroimaging and when. This is the other example where you again should look at your threshold for neuroimaging should be very low. Is this the patient who, as you see here, there is a ptosis? She had a third nerve palsy around 3 months ago. She came back saying there is a remarkable improvement, but just the ptosis which is persisting. Let's see here what happens when the patient looks to the left. Look at the eyelid of the left eye very carefully, and you'll find here patient is adducting. Adduction seems to have come back fine as well. Patient looks up and you say that elevation is not fully improved. But what I want you to see is a sign of aberrant regeneration, but there is a clear lid lag and a complete disappearance of ptosis when the patient looks down, which is one of the signs of aberrant regeneration. There are Three signs of aberrant regenerations clinically that you should be on the lookout for every patient of third palsy which improves. One, when the patient looks down, there can be a lid lag. It is also called a pseudo-1 Duffy sign. When the patient adducts, there will be widening of the palpebral fissure. That's also called inverse Duane syndrome. And when the patient adducts, there can be constriction of the pupil. That's sometimes called Zernike's sign. So these are the three signs of aberrant regeneration which you should be on the lookout for when there is a third palsy which has resolved. Now, why I'm emphasizing on the aberrant regeneration, because you have to remember that aberrant regeneration is almost never seen in ischemic cerebral palsy. So if you find a patient with aberrant regeneration and you find that patient has not been investigated, that patient surely is a candidate for further investigation. So let's, third palsy, look for anisocoria, look for larger pupil, look for aberrant regeneration, and look for involvement of other nerves, especially the fourth and the fifth nerve. Look for corneal sensation, look for intorsion in a down gaze to see whether fourth nerve is involved or not involved. Now, why we are harping on this? Because one of the important causes of a third palsy is aneurysm of posterior communicating artery. Now, 86% of the patients who harbor aneurysm would present with third palsy with involvement of pupil, with larger pupil on the same side. So what it tells you is that 14% of the patients who are harboring aneurysm would still present to you with normal pupil. So these patients require, even if the pupil is normal, according to a conventional older thought, these patients would require continuous follow-up to see whether pupil is getting involved little later in the course of the disease. And why this is important? Because these aneurysms, especially these aneurysms which are not very large generally, 10% of these patients would die before medical attention because of subarachnoid hemorrhage. 50% of them, they die within 1 month. And the remainder will have residual permanent neurological deficit. So a patient who walked into your OPD would have a high chance of morbidity and mortality, and that's the reason why we are worried about a third palsy. Now, this is 2002 enrollees recommendations, where he says that if there is a complete third palsy, complete ophthalmoplegia, and pupil is spared, there is a lower risk and you can observe. Rest all carry a risk of patient having a compressive lesion of the third nerve, and the commonest compressive lesion would be aneurysm of PCOM. The newer thinking has been, because there have been anecdotal reports of patients who present with complete ophthalmoplegia and pupil sparing in here, but also on neuroimaging because of some other reason were found to have a lesion which was responsible for third palsy. And as I said, because what you can miss out if you don't do neuroimaging can be fatal or can have a massive morbidity for the patient, the newer thinking is that almost all third palsy patients would require neuroimaging. Now, what neuroimaging that you are requesting for? MRI brain and orbit to begin with very low threshold for angiography. So you need to speak to your radiologist. If he finds a reason for third palsy in MRI brain and orbit, then he does not need to do anything further. But in most instances, he will end up doing MRI with MRA. There has been a great debate between a merit of MRA versus CTA, but I personally do MRI with MRA and it will pick up most of these aneurysms. There have been practitioners who have a very low threshold for even advising conventional angiography because, as I said, because the disease that you're missing out can have a fatal consequences. So even if MRA is normal, but you have a strong suspicion, pupil is large, there is a partial third palsy, patient has pain, patient has a family history of aneurysm. These are the patients who might actually end up having conventional angiography, invasive angiography to see whether patient has aneurysm. So that's about the third palsy. But this is the second patient who comes to you with acute onset of headache and neck pain. And must acknowledge Dr. Devendra, who shared this beautifully documented patient with me. You can see that there is a mild ptosis of the left side. And you look at the pupil, because one of the facets of the talk is the pupil. So you look at the pupil. Now, when you look at the pupil in this instance, you are actually worried about the efferent side of the pupil. So you want to see whether is there any anisocoria, number one, and number two, what happens to anisocoria in dim illumination and a bright illumination. And as you see here in dim illumination, this pupil is dilated, this pupil is not really dilated that much, and in a bright illumination, the pupils are of normal size. So in other words, the anisocoria is worse in a dim light, telling you that this patient has a sympathetic system problem of the left side, patient has a Horner syndrome. So what do we do next? Now, any residents in the audience would always come up with the answer saying, we would like to do cocaine test and hydroxyamphetamine test. Well, I have to tell you that the access to cocaine has become disappointingly low. And that's the reason why these pharmacological tests have given up. You have to find out in an acute onset Horner syndrome, and these are some of the causes of acute onset Horner syndrome, why you're worried about in acute onset Horner syndrome, and why do you get ptosis. You get ptosis because of paralysis of Muller's muscle, which is responsible for 2 millimeters of excursion. So the ptosis generally is very mild. And if you have an isocoria, acute onset, what you're worried about is dissecting carotid aneurysm. And this is a paper by Valerie Bu's beautiful paper, which said that 44% of these patients had dissection, and 32 out of 65 patients who had this dissection, actually Horner syndrome was the only sign of dissecting carotid aneurysm. So if you find mitosis, if you find a small pupil on the same side, you're probably dealing with a neurological problem. You're probably dealing with a serious neurological problem. So that patient needs an immediate referral. If you are going to manage it by yourself, patient, your area of interest is actually neck and chest. 78-year-old female with bilateral ptosis, and this is something which Akshay touched upon. You see, when you keep examining this patient has a ptosis and it will keep increasing as you examine. Another subtle sign which you should look at, which I found very useful, is that you find this lid fluttering. When you check the oculomotor, there can be mild flutter, which I feel is an extension of Kugan's lid twitch. And you find here, patient looks down for 15 seconds, makes an upward saccade, and there is a very impressive Kugan's lid twitch. These are the signs of oculomycin. As Akshay mentioned, there is no single test which will give you a definitive diagnosis of pure oculomycin, and you have to rely on these clinical signs like Kugan's lid twitch, lid flutter, fatigability, eyes test before you diagnose these patients. And you also have to remember that this looks very similar to myasthenia, but how to remember involution ptosis behaves very much like myasthenia as far as fatigability is concerned. So the index of suspicion in these patients before you operate should be high. 8-year-old female, unreliable history. She was posted for the operation of congenital ptosis, but you see clearly there is a presence of lid crease. Again, an index of suspicion should be high, and this patient actually was found to have myasthenia. We switch tracks and see this patient bilateral ptosis, symmetrical ptosis associated with complication of oculomotility. Patient is not able to look to the left, to the right, up and down. This was something which she developed around 3 or 4 years ago, and over a period of time, her condition worsened. Obviously, we are dealing with CPEO, or chronic progressive external ophthalmoplegia. There are two myopathies that you should be familiar with. CPEO, generally seen or onset is in younger age group females. You need to look at the fundus, rule out pigmented retinopathy. Also, refer these patients for cardiologist evaluation because they have higher association with a heart block, which again can be fatal. Myocardial dystrophy, generally seen exactly opposite spectrum. Older age males would have an associated ocular features like pupillary abnormality, Christmas tree cataract, and even glaucoma. One of the important markers of myocardial dystrophy is you shake hands with the patient, and because they have a problem with the calcium channel, you'll be able to shake hands, but you'll not be able to loosen the grip. That's one of the reasons why they develop ptosis as well. So that's about myopathy. Another important examination point, because we're dealing also with palsy, is the patient has complete ptosis. Let's see what happens when the patient is checked. Patient looking to the right, no abduction, no elevation, no depression, and no adduction. That means you are not dealing with third nerve palsy, but you have a third and a sixth nerve palsy. Patient's corneal sensation also was impaired on the same side, so probably looking at orbital lesion or a cavernous sinus lesion. Look at the optic nerve function test. If the optic nerve function test is fine, you're probably looking at superior orbital fissure or cavernous sinus. These patients will require MRI to make sure to rule out an inflammatory versus a compressive lesion. This is an interesting patient I wanted to show you. He came and said that when he reads for a longer period of time, his eyelid droops. Look at what happens. Just see the video carefully and see what happens. It's a little longer video. And as we were following up the patient, we actually knocked off the cataract. You see, when the patient is trying to look to the right, up, down, the eye movements are very, very slow. His presenting problem was lid drooping after prolonged reading. And see what happens when we are examining the oculomotility, and suddenly you'll find that the eyelids were closed. And this is what his complaints were. And then he says that he has to do this, right eyelid opened up nicely. And then after some time, so he was told that he probably has myasthenia because prolonged reading, drooping, you can see a little ectropia as well. But he also had Parkinsonism, and these patients can have associated oculomotor or lid apraxia, and that's what this patient had. So in other words, all adult onset ptosis, always look for neurological aspect of ptosis. Third nerve and Horner syndrome are two things that you're looking at as far as the nerves are concerned. Myasthenia is neuromuscular junction, and myopathy is about the muscle. Look at the movement of the lid, that'll give you a clue as to what's going on. Pupil, as part of the title as well, is extremely important. Any involvement of pupil, you're very sure that this is not congenital or involution process. You're also sure that this is not like myasthenia, because myasthenia, pupil is never involved, and oculomotility, of course, will give you a clue. And what happens if you miss out on any of this? This is an unfortunate patient who underwent a surgery. You can see the ptosis scar here. And following this ptosis surgery, he developed this weird kind of oculomotility where eyes were not moving properly. So basically, he had some weird form of ocular myopathy, but he ended up blaming the surgeon. And he said that all this started after the ptosis surgery was done. And that's the importance of ruling out any of these mimickers of ptosis. Thank you, Akshay, and thank you for your